and organizers and Dr. Salam for inviting me to this session. I will speak now about the case of two intraocular foreign body inside the eye. Fortunately, I don't have a trauma cases here in Dubai. I don't do, but this case was done in Damascus 20 years back. So how I can get the next slide, please? The video, please. Yeah. Can you start? Can you press on it? Yeah, this case was referred to me after the primary repair, and the case already was aphakic. Of course, vitrectomy was done, and two intraocular foreign body was inside the eye. This was the first one. Always I stop before getting the intraocular body outside the eye. I think what is the best way to get it outside the eye. Here I did by manual maneuvers to get the foreign body along his axial axis and get it outside the eye. The second one was embedded in the inferior part of the retina, and it was quite larger than the previous one. Also, I stopped here. I did by manual maneuver using my both hands to direct the foreign body to get it through the shorter axis in order to avoid enlarging the sclerotomy. And I used the ring forceps. Usually, now I don't use the same sclerotomy. I create another one, but that time I enlarge the sclerotomy, and I use this 16 gauge ring forceps, and I get the foreign body outside the eye. At that time, I use the perfluorocarbon to protect the macula if the foreign body will fall down. I don't know that there is a debate if this work or not. And also, I use the Brolin suture to fix the lens at the sclera. At that time, almost always, if the patient is aphakic or I will do the cataract during the surgery, I prefer to insert the IOL at the same session to avoid the synechia. And this was the eye at the end of the surgery. Last one. Second slide, please. No, the second one, the last one. Yeah. So there are a question for the panel. So what do they prefer to get the foreign body in this case through the sclera or the anterior chamber as far as the patient was aphakic? And which type of suture do they prefer to use to fix the IOL? Because now we have another type of suture like Gore-Tex, and somebody, if they do prefer to do the Mani technique. And what about the iris defect? What is the type of the fixation of this iris defect, and if they are going to do it in the same session or not? Yeah, thank you very much for.
Thank you, sir.
Good afternoon, everybody. I would like to thank Dr. Amri and the organizing committee for this invitation. My case today is about perforating injuries, which carries a much more worse prognosis than intraocular foreign body. And you have to take care of these cases all the time. And this is the case which presented to me, and I thought that this is a lucky patient, because this patient, as you can see, his macula is almost flat, although he has dense hemorrhage, pre and intraretina with perforation nasal to the optic disc, but the macula was okay. And this patient, this is the red free of the patient. This patient had a CT which showed a penetrating trauma to the right eye. A small pocket of fluid is seen abutting the posterior aspect of the sclera, just medial and inferior to the optic disc. And this is very important to have a CT for all cases of penetrating trauma. This is associated with vitreous hemorrhage, is still preserved orbital contour, and as you can see in the final diagnosis, there was pellets along the maxillary bone outside the globe, so there is no intraocular foreign body, and the CT, as Noor told us today, is much superior in localizing the foreign body if you are going for surgery. I got to go to do vitrectomy for the patient, and as you can see, this is the right eye of the patient. His macula was almost free. Some hemorrhage, which is not very important, but the main bulk of the hemorrhage was down and nasal to the optic disc, as the CT had clarified. I'm trying to dislodge all the hemorrhage from the down of nasal area of the perforation to clarify this area and to treat it. After several trials, the retina was really a little bit free of the hemorrhage. There was some temporal choroidal detachment, as you can see in the video, but this was not very important. Now I had got to the area of the double perforation. I had applied endodiscermy to this area of the perforation to highlight this site, as I'm going to do laser photocoagulation. And as you can see, scleral depression is very important to remove the bulk of the hemorrhage from the vitreous base. By the way, this patient was phakic, he's not aphakic. And now this is the laser at the end of the surgery, and the retina was flat. And I had to put silicone oil for the patient because of the prognosis on the long term. Although this patient looks to be very nice, with the down and nasal perforation away from the fovea is attached, but you have to anticipate problems along the way. This was the post-operative appearance in the first week. As you can see, the site of the posterior perforation was laser, the retina was flat, and other fields of the retina. There was some temporal choroidal detachment under the silicone oil, but this was not very grave. And this is the composite picture of his fundus. This was like 1 week along the surgery. The patient I told him that he have to return after 6 months to remove the silicone and to remove the lens and put an IOL, in anticipation that he's going to develop some cataract. And this was the picture 6 months after the surgery. As you can see, there is subretinal fibrosis along the macula, although at the surgery and in the post-operative period, there was no fibrosis. The retina, although the retina is flat, but still there was fibrosis. I was accused or criticized at the time of the surgery why I didn't do chorioretinectomy to the area of the perforation, and that would decrease the index of fibrosis. I don't believe in that, but maybe somebody is believing in that. So I went to remove the silicone oil, remove the lens first, implant an IOL, and remove the silicone oil. And as you can see, the site of the perforation was lasered thoroughly and flat. But I have to go to remove some of this fibrosis. I did realize that this fibrosis temporal to the fovea was in part intraretinal, so I didn't go ahead and remove it. I did remove only the superficial layer. There was subretinal fibrosis along the down and temporal area, and as you can see, it was tenting the retina, so I don't have to leave it like that. I have to remove the subretinal fibrosis, and this did occur along the temporal side, very away from the site of the original trauma. The subretinal fluid did come away. I had to mark the site of the retinotomy, again, flatten the retina by laser and apply laser to the retinotomy. I did search along the different part of the retina. I didn't find any other break, although on the long way, you can't anticipate some more problems. Again, laser to the drainage or the retinotomy for removal of the subretinal fibrosis. The take-home message that perforating ocular trauma carries a guarded prognosis. Although you have good prognostic signs that the foreign body didn't pass through the fovea, but you have to anticipate problems along the way. Long-term follow-up is warranted. Complication can occur after successful primary surgery. Chorioretinectomy, I don't know if it's helpful or not, should be studied as a method to prevent long-term reproliferation. Silicone oil removal should be judged on individual cases, because in some cases you may think about leaving the silicone oil for a longer time. You're afraid that you lose the retina and it becomes detached. I would like finally to invite you all to the next Bridge Retina meeting, which is going to be in Al-Amin City on next May, the new beautiful city of Egypt, and I would like to have you all there. Thank you.
Thank you very much. And I would like to thank the organizing committee and Dr. Alamri especially for providing me an opportunity. So my case is 30-year-old male who lost his vision in the left eye, and the duration was around 4 weeks. And if you look at the history, 10 years back, he had a bomb blast injury. At that time, he had full thickness corneal laceration, as well as iris damage and cataract. So initially, primary corneal repair was done, and later he had cataract surgery and iris damage was repaired. So one of my colleagues referred this patient with retinal detachment. So vision was 6 by 6 in the right eye, and in the left eye it was counting finger. And on examination, I could see a corneal scar with iris defect that was repaired with Proline, and patient was pseudophakic. On further examination, I noticed that there is posterior vitreous detachment present, there was tobacco dust there, and there was inferior retinal detachment with macular involvement. I noticed peripheral retinal break around 6 o'clock, but I also noticed there was a large glass foreign body, which my colleague didn't mention, and there was no mention of it was even previously. The surgery was planned and successfully executed. So I'll go to the video. 25 gauge pars plana vitrectomy was done, and you can see that the iris defect is there, and this was the foreign body that was lying there. So I started with the vitrectomy. It's very important. You need to mobilize it. I needed to make sure that the PVD is present, and once you have removed the vitreous around, I'll plan to remove it. Because the patient is pseudophakic, so my plan was to give the scleral incision and remove it through the sclera. So now I'm doing conjunctival parotomy locally, and it's very important to have bleeding stopped. And once it's stopped, I'm giving the incision. An important thing here is to give a large NF incision. You don't want that it's stuck and drop down. You can use heavy liquid, but if you're cautious, you won't hit the disc or macula. So here I have enlarged the incision, and what I'm doing is I'm using my light pipe to push it, and this was taken out, and the foreign body was taken out. So first important thing is there is a hypotony, there is a detachment, so you need to close your wound. So that I'm doing with 6 of Vicryl. So once the wound is closed, I'm going to mark the break. Shortly you will see that's a break here. And once it's marked, there is a grade B PVR there as well. So I did a retinotomy inferiorly because it would be difficult to drain from that area, and I want to have a good drainage because I was planning to put the gas bubble. So I'm creating the retinotomy and fluid air exchange. Once I've done that, I applied the laser to the original break, retinotomy, and there was a suspicious area at 7 o'clock position that I also lasered. And in this case, I used isovolumetric concentration of C2F6, and patient had retina attached. with good vision improvement. So here I'm doing laser. So similarly, I'll do it to the retinotomy site as well. And the gas is used, so I'll just move over. So retina was attached, vision improved to 6/9 at 6 weeks. So key learning points here. Important thing is that initial assessment is very important in such cases, especially the bomb blast cases. Foreign body can be anything. It can be vegetative, it can be cement, it can be metallic. So it's really important to do the scanning in such cases. After cataract surgery, again, it was very important. That was missed opportunity. Fundus examination was done at that time, and glass foreign body should have been identified. And it's really important to make a large incision to remove it, because small incision, you are having chance that it will drop down. In discussion, I think important things are, was it better to remove the intraocular foreign body if it was diagnosed earlier? Although glass is inert, but if I were at that place, I would rather remove it if it was found at that time. Would it be removed through the corneal incision or sclera? Well, in this case, basically pseudophakic patient, so it was easier to remove it. But if the primary surgery was conducted, when the cataract surgery was done, it was better to remove through the posterior capsular defect to the cornea. Coming to the tamponade agent, again, it's an important thing, grade B PVR, foreign body there, but I just decided to use the gas. The reason being, it's only one surgery will be required. Second thing, you get a better visual outcome by using the gases instead of the oil. So thank you very much. These are a couple of the lakes in Pakistan which I visited in summer, so I just thought to share with you. Thank you very much.